Welcome back, guys. Now in this video, let's discuss about normocytic anemias where there is predominant extravascular hemolysis. Okay. Normocytic anemias with extravascular hemolysis. Okay. So, normocytic anemias with extravascular hemolysis, here you know about everything. Normocytic anemias, which means the mean corpuscular volume of the RBC is going to be between somewhere 80 to 100 femtoliters, and extravascular hemolysis means the hemolysis is happening especially in the reticuloendothelial sites, that is liver, spleen as well as the lymph nodes. See, in this extravascular hemolysis, the first type of anemia that I am going to discuss here is hereditary spherocytosis. Okay, hereditary spherocytosis. Hereditary means this is an inherited condition. Okay, it's an inherited. It's an inherited disorder. Okay, it's an inherited disorder of RBC cytoskeleton, because of which there is spherocytosis. Okay, it's an inherited disorder, sir. Okay, of what? RBC cytoskeleton. The RBC cytoskeletal proteins are getting mutated, because of which the RBCs are going to become like a spherocyte. Spherocytes means what? Spherocytes are nothing but round shaped RBCs. RBCs are of which shape? Round shape. Now in hereditary spherocytosis, okay, in this disorder, which proteins are most commonly affected? See, you need to understand this. RBCs is having this biconcave shape, right? The RBCs are having this biconcave shape, which is very much important for the flexibility of the RBC to pass through the spleen. Now, what is the problem in hereditary spherocytosis is, sir, the proteins, the cytoskeletal proteins which are helping in this biconcave shape are getting mutated. The most common proteins that are getting affected is, first number one protein is ankyrin. Okay, it's ankyrin, it's the most common, followed by spectrin, okay, and band 3.1. See, these are different types of proteins which are present in the RBC cell membrane. Okay, these are actually cytoskeletal proteins. See, these proteins are helping in maintenance of the biconcave shape. Now, when these proteins are mutated, now the shape of the RBCs is going to go from biconcave shape to round shape. Okay, biconcave shape to round shape. See, what actually happens is, in the beginning, so because of the mutation of the cytoskeletal proteins, okay, because of the mutation of the cytoskeletal proteins, now the RBC membrane will become loose like this. So this RBC membrane will form a little blebs, little extensions. Okay, it's going to form these little extensions. Now such extensions, this is nothing but a cell membrane, right? See, when this RBC, when it is passing through the spleen, okay, when it's passing through the spleen, see, such extra membranes, these are removed by the splenic macrophages. They are removed by the splenic macrophages. So with the time, the RBC is losing its membrane. The RBC is losing its membrane, so that at the end of the day, RBCs will become round shape. Okay, now they cannot maintain that biconcave shape. Now they are becoming round shape. Okay, now such round shaped RBCs. See, there is no problem with the function. The function is absolutely okay. The round shaped RBCs cannot easily maneuver through the splenic capillaries. The round shaped RBCs cannot easily pass through the splenic. These round shaped RBCs are going to be captured by the macrophages, and the macrophages will destroy this round shaped RBCs. So what's happening? There is hemolysis happening within the spleen. Okay, so the spherocytes are destroyed in spleen. They are destroyed within the spleen, sir. Okay, so this is the point which I want you to know. This is the extravascular hemolysis. As the RBCs are getting destroyed in the spleen, so more and more number of, like, the RBCs are getting destroyed in the spleen. extravascular hemolysis. So what happened to the spleen size? The spleen size is going to greatly increase. So these patients are going to have splenomegaly. Okay, these patients are going to have splenomegaly. Okay, this is the one thing which I want you to know. See, the second thing, when you look at the peripheral smear, in the peripheral smear, see the RDW, red blood cell distribution width, RDW is going to greatly increase because see there are millions and millions of RBCs. See, some RBCs are going to will be in the big size and some RBCs are going to be small size, because that RBC which is younger is going to be big size, and that RBC which is older or elder RBC is going to be small size, because say for example imagine this is a younger RBC which is losing its cell membrane and becomes round. Now with the time more and more blebs will come, those blebs will be removed by the splenic macrophages. So at the end of the day the RBC size will decrease. So in the circulation you will see bigger RBCs than the younger RBCs and smaller RBCs. So red blood cell distribution width is going to be greatly increased. This also we have discussed then the iron deficiency anemias. In iron deficiency anemias also the red blood cell distribution width increases. Next, what about the MCHC? That's a mean corpuscular which RBC, mean corpuscular hemoglobin concentration. We are removing the cell membrane, the cells are becoming smaller in size. Okay, so now there is no problem with the hemoglobin. The cells are becoming smaller in size. The cytoplasm is getting smaller and smaller, okay, lesser and lesser, with the same amount of hemoglobin. So hemoglobin concentration, the relative concentration with the cytoplasm is increased. So mean corpuscular hemoglobin concentration increases. Okay, simple normal hemoglobin is there. You are just reducing the cell volume. So for that particular cell volume there is more hemoglobin, because the cell volume is getting decreased. Okay, decrease in the sense little decrease, not too much. Okay, because these are normocytic anemias. Usually the cell volume will be maintained between 80 to 100 femtoliters. Cell volume is getting decreased. So hemoglobin concentration relatively increases. Mean corpuscular hemoglobin concentration increases. Okay, now next the important point which I want you to know is, so usually when you see an RBC, okay, when you see an RBC, RBCs are going to look something like this. See, this is the RBC. From top view I am showing you. Okay, side view it's going to look like this with the biconcave shape, but when you look from the top view something like this, so in the center you are going to have the central pallor. Okay, whiteness will be there, and in the periphery hemoglobin more red color will be seen. Okay, more red color will be seen. This is how the RBCs are going to be. Okay, let me show you the picture once with the previous anemias. See, for example, look here, when you are seeing the RBCs from top, here in the center there is a central pallor. Okay, but in our condition, the hereditary spherocytosis, that central pallor is going to be lost. Okay, that central pallor is going to be lost. Loss of, because RBCs are getting smaller. Okay, smaller. So there is no such thing as biconcavity. Now it's totally round RBCs. Okay, it's a totally round RBCs. The hemoglobin is going to be evenly distributed. So there is no such thing as central pallor. So loss of central pallor. Okay, loss of central pallor is seen. I have said you, so these are the extravascular hemolytic anemias. Okay, extravascular hemolytic anemias. So every day more and more RBCs are getting turnover. Okay, more and more RBCs are getting destroyed in the spleen. So spleen unnecessarily is destroying this round shaped RBCs. So then more and more RBCs are getting destroyed. Who is going to be released? Hemoglobin is going to be released. So hemoglobin is going to break into heme and globin, you know it. So at the end of the day, hemoglobin is going to split into heme as well as globin. Okay, heme as well as globin. Now the heme will be further split into the iron which is used by the body and protoporphyrin. So this protoporphyrin production increases. Okay, the protoporphyrin production increases because more amount of RBC turnover, more hemoglobin is getting breakdown, the more protoporphyrin is getting produced, the protoporphyrin is getting converted into, further broken down into unconjugated bilirubin. So unconjugated bilirubin levels greatly rises. So I have already explained in the previous video, it's the liver which converts the unconjugated bilirubin into conjugated bilirubin. Okay, this unconjugated bilirubin in the liver, it is converted into conjugated bilirubin. Now as there is excessive amount of hemolysis, excessive hemoglobin breakdown, excessive amount of unconjugated bilirubin is there. So this unconjugated bilirubin is the one which is going to cause jaundice symptoms. Okay, it's going to cause the jaundice, and at the end of the day, the unconjugated bilirubin is getting converted into conjugated bilirubin. So this conjugated bilirubin, where it will go, even it's getting elevated. Okay, more conversion is happening because the raw product is more, like there is more raw product, the unconjugated bilirubin levels are more. So this unconjugated bilirubin at the end of the day in the liver is getting converted into conjugated bilirubin. So this conjugated bilirubin, where it's going into bile. So in the bile, the conjugated bilirubin levels increases. So this conjugated bilirubin in the bile, it can react with the calcium and forms the calcium gallstones. There is a risk of calcium gallstones. I should say the calcium bilirubinate gallstones. Calcium bilirubinate gallstones. So these are the points which I want you to know in a patient who is having, these are the side effects actually. The calcium bilirubinate gallstones are going to be seen, jaundice symptoms are going to be seen. Okay, under microscope what you can see is loss of central pallor, round shaped RBCs, increased RDW, mean corpuscular hemoglobin concentration is going to be increased. Okay, and one of the screening tests for this condition is screening test. One of the screening tests for this condition is Nestrov test or osmotic fragility test. So what is, if you ask me, so what is this osmotic fragility test? Osmotic fragility test means, say, now imagine here I am taking a hypotonic, okay, hypotonic saline. Hypotonic saline. Okay. Now here I am keeping the RBC. Now let's keep the RBC over here. Imagine this is the normal RBC. I am keeping a normal RBC in the hypotonic saline. Now we know water always moves from low osmolarity to high osmolarity. Here the osmolarity is low. Here the osmolarity is more. Okay. Here osmolarity within the RBC is more. Outside it is hypoosmolar, hypotonic saline. So what happens, usually water will try to enter into the RBC. Okay, water will try to do what? Let me show you here. Water will try to enter into the RBC. But a normal RBC is having extra membrane, enough amount of membrane. That extra membrane is there. So this RBCs, upon taking this water, they will become round in shape. Okay, by taking that water, they will become round in shape. Okay, here the space is not enough and they will become round, big round cells. But in a patient who is having hereditary spherocytosis, what will happen? Say, already their RBCs, okay, already their RBCs are round shaped. Okay, so is there any extra membrane for them? Is there any extra cell membrane for them? No, they are already become round shaped. Now here in the hypotonic solution, you keep these round cells. Now what happened? Now when you keep these RBCs, yes, water will go, no doubt. But there is not space, there is no space enough. So immediately RBCs will start to rupture. RBCs will rupture because they cannot accommodate any water, because already their size is they are not having enough space. So there will be osmotic fragility. Okay, osmotic fragility is going to be seen in this patient. Now, so this patient, what is the treatment? What is the treatment that we can do for this patients who are having hereditary spherocytosis? The treatment is going to be the main culprit. Look at the culprit. See, there is no problem with the round shaped RBCs. If they are round shaped RBCs, okay, not an issue. They are still doing their job. They are carrying the oxygen and they are properly delivering the oxygen to the tissue. There is not even problem with the hemoglobin. Everything is absolutely good. It's just the shape, sir. It's just the shape of the RBCs are wrong. So who is doing the destruction? It's the spleen who is doing the destruction. So we have to take out the spleen. So splenectomy. Okay. So what we are going to do is splenectomy, sir. Okay. Splenectomy is the treatment that is done for hereditary spherocytosis. So if you just remove the spleen, everything is going to be normal. Yes, of course, still the RBCs are going to be round shape because the extra membrane, whatever is coming, that extra membranes, okay, because of this spectrin and ankyrin, especially ankyrin, because of this ankyrin mutation, the RBC membrane is not having proper tensile strength. They are forming these extra membranes. Yes, when these RBC, when they are going through the lymph node or whenever they are going to the liver, yes, that membrane will be removed and still you can see the round shaped cells. Okay, but the RBCs are not getting destroyed in the spleen. So splenectomy is the treatment. And what else is important points? See, in these patients, after doing splenectomy, you can see cells, RBCs, with Howell Jolly bodies. Howell Jolly bodies. Sir, what are these Howell Jolly bodies? Howell Jolly bodies are nothing but the fragments of the nucleus. See, for example, if this is the red blood cell, if this is the red blood cell, now the nuclear fragments, okay, usually if by chance if there is any RBC that is coming into the peripheral circulation with some amount of remnant nucleus, see, such cells are captured by the spleen, and those cells will take out this cells, okay. So they will try to remove this nucleus, or sometimes they will totally destroy this RBCs, okay. They will totally take out the cells. As the spleen is not there, spleen is the main checkpoint, always looking for the good RBCs, okay. They are always checking whether the RBCs are in proper shape, proper size, everything is normal or not. As the spleen is not there, the checkpoint is not there, you can see these RBCs with some amount of nuclear fragments. So these nuclear fragments are called as Howell Jolly bodies. Okay, these are nuclear fragments. Okay, so with this we have completed the hereditary spherocytosis. One important point which I want you to know is that in these patients, continuously throughout the day, okay, the spleen, what it is trying to do, the spleen is trying to remove the RBCs. Continuously throughout the day, the spleen is trying to remove the RBCs continuously. Okay, see, you and me, okay, who are actually normal, see if today right now, if you stop producing the RBC, WBC and platelets in my bone marrow, it's not a big deal, sir, because whatever the RBCs are there in my body, it's going to be there for the next 120 days, so they will try to manage the things. But in these patients, continuously there is hemolysis, and bone marrow is trying to produce as much RBCs as possible, so their bone marrow should always produce the more number of RBCs to compensate the loss, So in these patients, 2 points which I want you to know is, if you check for the reticulocyte count, the immature RBC, the reticulocyte count is going to be more than 3%, because the bone marrow is still okay and it is trying to compensate the loss. So reticulocyte count is going to be more than 3%. And one more point which I want you to know here is, see, in these patients cannot afford certain infections like parvovirus B19. If they get this parvovirus B19 infection, they are going to have a plastic crisis, which means, see, usually this parvovirus B19, it's going to cause something called as, it's going to affect the bone marrow, and it's going to cause pancytopenia, okay. It causes pancytopenia. It's going to cause pancytopenia, means decrease in RBC, WBC, platelets, okay. But if it happens in you and me, that's okay. It's a self-resolving condition. If it happens in you and me, within a week we are going to come back to normal. But in these patients, continuously hemolysis is happening. His bone marrow have to continuously produce the new RBC, WBC and platelets. Okay, so in this patient there is continuous extravascular hemolysis. So this patient cannot afford this infections, parvovirus B19. If he gets this parvovirus B19 infection, then there will be a plastic crisis that's going to be seen in these patients. Okay, so with that we have completed all the important points which you need to know for your hereditary spherocytosis. After hereditary spherocytosis, the next topic is sickle cell anemias. Sickle cell anemia. So what is the sickle cell anemia? What you should know for your exam. So sickle cell anemia is a qualitative defect. So what is this qualitative defect? Qualitative defect of what? Qualitative defect of hemoglobin. Now this is a not normal hemoglobin. See, quantitative problem of the hemoglobin is seen in thalassemia. Here is a qualitative defect. So what is this qualitative defect? And let's discuss some important points about this sickle cell anemia. So sickle cell anemia, it is autosomal recessive disorder. Okay. In this condition, what happens is, so there is a mutation. Actually, it's a point mutation in beta globin gene. There is a point mutation in the beta globin gene. So what exactly is happening in this condition is, so one type of amino acid is going to be replaced with other type of amino acid because of this gene mutation, point mutation. Okay, because of this point mutation in the beta globin gene. So just for completion purpose, I am telling you the beta globin gene is present on chromosome number 11. So there is one point mutation, sir. Because of this point mutation, what happens is, sir, the glutamic acid is replaced by valine. The hydrophilic glutamic acid is replaced with hydrophobic valine. So because of that one single point mutation in the hemoglobin, in the beta globin gene, for example, look here. So this is beta globin protein. This is the beta globin protein, not gene. This is the beta globin protein. Beta globin, you know it, right? Alpha globin, beta globin, 2 alpha, 2 beta, 2 alpha, 2 beta. This is the beta globin protein. Okay, our beta globin chain. Now here, what is this? Here it was supposed to be glutamic acid. Okay, it was supposed to be glutamic acid. Now here, instead of glutamic acid, it was replaced. Okay, this glutamic acid, it is replaced with some other amino acid, that is valine. So because of this, now this is not a normal hemoglobin. This is a defective hemoglobin. The quality of the hemoglobin is altered. Now this hemoglobin is called as sickle cell hemoglobin. Okay, this is called as HbS. Okay, HbS, sickle cell hemoglobin. Normal hemoglobin is Hba. This is sickle cell hemoglobin, HbS, sir. Now, what's the problem? Let me discuss one by one. See, the sickle cell disease arises, okay, usually, look here, this is chromosome number 11. Okay, this is a chromosome number 11. One from the mother, one from the father. Now, here is the gene. Look, here is the gene. See, if one gene is defective, say for example, this is a beta gene, right? For example, it's coding for beta. This is something normal. Now, the mutation occurred on this chromosome. Now, the mutation occurred on this chromosome. Now, it becomes beta S. Okay, so this is sickle cell. It's going to code for defective beta chains. Okay, it's going to code for the defective beta chains. So, this patient now is having one beta gene which is going to code for normal beta chains, So, from here HbA is going to be produced, HbA is produced. But here the beta genes are defective. So, definitely it is not going to code for normal beta chains. So, here the beta chains are defective. So, it is going to code for HbS. Okay, HbS, sir, sickle cell hemoglobin. So, what I want you to know is, sir, this type of combination, in this patient normal hemoglobin is there and sickle cell hemoglobin is there. So, these patients are called as sickle cell traits, sickle cell trait. So, sickle cell trait means one gene mutation, one gene, okay, on the two genes, one gene is mutated. So, 50% that, 50% this, 50% normal hemoglobin, 50% sickle cell hemoglobin. Now, what if, look here, what if, sir, the patient is having two chromosomes, two 11 number chromosomes, both the beta genes are mutated, both the beta genes are mutated. If both the beta genes are mutated, now what will happen? They will code for which type of beta chains? They will code for defective beta chains, not normal beta chains, defective beta chains. So, it is going to code for defective beta chain, it is also going to code for the defective beta chain. So, what happens? So, these patients will have hemoglobin S, hemoglobin S. So, completely there is not normal hemoglobin, there is complete sickle cell hemoglobin, everywhere there is complete sickle cell hemoglobin. So, these patients are having sickle cell disease, not the trait, these patients are having sickle cell disease. So, with sickle cell disease there is a problem. Okay, with sickle cell disease there is a problem. Usually with sickle cell trait there is not a problem. It's a milder condition. It's a milder condition, not a big problem, sir. With sickle cell disease there is a problem. Yes, there is a problem. What is that problem? See, this sickle cell hemoglobin, it's okay, sir. It's normal. It's functioning normally. But when you expose the sickle cell hemoglobin to certain conditions, Okay, certain conditions, certain extreme conditions like hypoxia, acidosis, dehydration. Now, if you expose this sickle cell hemoglobin, it will undergo polymerization and forms a sickling. So, the sickle cell hemoglobin, what it will do? It will undergo sickling. So, what exactly is the sickling, sir? So, because this HbS, sickle cell hemoglobin, the one important point about the sickle cell hemoglobin is it will undergo polymerization. Polymerization. This is not normal hemoglobin. It will undergo polymerization when which conditions? Hypoxia. When you expose this, okay, sickle cell hemoglobin to hypoxic conditions. Where is hypoxic condition? In our tissues, yes, there is hypoxia, relatively there is hypoxia. When you expose this sickle cell hemoglobin to hypoxic conditions, it will undergo polymerization. Okay, now because of this polymerization, do you know how the RBCs will become like? The RBCs are going to become like a sickle shaped. Okay, RBCs will become banana shaped or sickle shaped. See, this polymerized HbS, the polymerized HbS within the RBCs, they are just like spikes, they are just like needles. They will start to damage the RBC cell membrane. Okay, this polymerized sickle cell hemoglobin, it will start to damage the RBC cell membrane. So, it is going to damage the RBC cell membrane. Okay, so right here, when polymerization is happening, polymerization, hypoxia or acidosis or dehydration. In all these conditions, yes, polymerization is occurring. Because of this polymerization, there are sickle cells. Sickle cells are going to be seen. So, what is the problem with the sickle cells? Say, I have said you, the sickle cells are going to have membrane damage. Membrane damage. So, whenever there is a membrane damage, what happens? Whenever there is a membrane damage? Whenever there is a membrane damage in the spleen, the RBCs are destroyed. RBC destruction. Okay, so the spleen wants to have a proper RBCs. Whenever the RBCs with the damaged membranes are encountered with the splenic macrophages are going to try to remove those RBCs. Okay. Now, what else you should know for your exams is, see, these patients with the sickle cell disease, for example, the patient with the sickle cell disease is going to show symptoms after 6 months after the birth. Okay, usually the infants, the neonates are not going to show any symptoms. In utero life, there are no symptoms because, see, in utero, which type of hemoglobin is there? HbF, which is made up of alpha 2, gamma 2. So, there is no point of beta at all. There is no point of beta at all. Okay, yes, the genes are mutated. It's going to code for, in the future, it's going to code for the defective beta globin genes. True. But right now, there is no beta chains in the RBCs. So, there is no problem at all. So, in utero, no symptoms. Even after the birth, the high amounts of HbF, okay, after birth, high amounts of HbF is protective. Okay, so not much symptoms are going to be seen. When this HbF is replaced, for example 6 months, is replaced with HbA. Now tell me what happens. So the HbF is getting converted into HbA, which means alpha 2, beta 2. Now beta chains are coming. So these beta chains are defective beta chains. These are not normal, these are defective. So as the defective beta chains, so it is going to be not HbA, it is going to be HbS, hemoglobin S, sickle cell hemoglobin. This sickle cell hemoglobin will start to damage the RBC cell membrane. So those damaged RBCs are going to go through the spleen and they are getting destroyed. Okay, so this is the one point which I want you to know. Apart from this, what else you should know is, sir, complications. Look at the complications. With the time, okay, the RBCs are undergoing sickling, decycling. Whenever the RBCs are going through the microcirculation, whenever they are going through the tissues, they are undergoing sickling, and whenever they are coming to the lungs, they are undergoing decycling. Is happening. RBC cell membrane destruction is happening. That's okay. But there will be a time the cells are totally sickled, and they are not decycling. They are totally sickled cells. Sickled cells are there. Now these sickled cells, do you know what they will do? Sickled cells will cause vaso-occlusion. The sickle cells are going to occlude the blood vessels. They will cause blockage of the blood vessels. Because of this vaso-occlusion, do you know what happens? So the blood supply to the tissues decreases. The blood supply, the blood flow to the organs is going to decrease. In the same way, say already in the kidney, there is, for example, if you look at the kidney, something like this. So in the kidney, look. So what is this? This is the renal pelvis. See, in the kidney, we know it. There is outer cortex and inner medulla. These are the renal pyramids. In the renal pyramid, this part is called as the renal papillae. Already there is very less blood flow to the renal papillae. Already there is very less blood flow. Now in this condition, what happens is, because of the occlusion of the blood vessels, so the blood supply to this region is going to be totally affected. Totally it's going to be affected. So this renal papilla, they will undergo necrosis. So these patients are going to have renal papillary necrosis. Renal papillary necrosis. So this is a very important point which I want you to know. So the patients with sickle cell disease are going to have renal papillary necrosis. True. Next thing, the blood vessels which are supplying the palms and soles are also going to be blocked. So these patients are going to have very much pain in the palms and soles. So these patients are going to have vaso-occlusive crisis. Okay, so these patients are having vaso-occlusive crisis. Vaso-occlusive crisis. Okay, vaso-occlusive crisis, and there is pain in fingers. Okay, there is pain in fingers because especially the blood vessels are getting blocked. Okay, the blood vessels are getting blocked because of the sickle cell RBCs, especially it's seen in the infants. Okay, third one point is, so the blood flow to the spleen is also going to be affected. The sickle cell RBCs are going to block the blood vessels within the spleen. So the spleen, with the time, it will totally undergo destruction. Totally the spleen is undergoing destruction. So this is called as auto splenectomy. So the total spleen is going to be lost. Autosplenectomy. As spleen is not there, so spleen is the site of immune system. That's the place where B lymphocytes are going to be matured. So when the spleen is lost, the patient is at a risk of, the patient is at a risk of developing encapsulated organism infections. Okay, capsulated organism infections. Spleen is not there, so chances of infection. So capsulated organisms. Okay, infections. This is a very important point. So splenectomy will increase the risk of infections with the capsulated organisms. So pain in the fingers, this is called as pain in the fingers is called as a dactylitis. Okay, dactylitis is going to be seen, renal papillary necrosis, autosplenectomy is going to be seen. So blockage of blood vessels to the lung will cause acute chest syndrome. Acute chest syndrome. The way the patient is going to have the symptoms of dyspnea, and this is a cause of death also. It will cause even death. Okay, it can even cause death because of the occlusion of the pulmonary microcirculation, and it's the most common cause of death. Okay. Now what else you should know is, see, in these patients, look, in these patients there is very severe hemolysis is happening. Okay, sickling, desickling, the sickled RBCs are getting destroyed within the spleen. Okay, and the reticuloendothelial system, the RBCs are getting completely destroyed in the extravascular system, in the extravascular side, that's the spleen, lymph nodes, as well as in the liver also. So in these patients, yes, there is extravascular hemolysis. As there is extravascular hemolysis, too much amount of extravascular hemolysis, tell me what happened to unconjugated bilirubin levels? Increases. More hemolysis, more unconjugated bilirubin. So because of this unconjugated bilirubin, more amount of unconjugated bilirubin, what happened to the patient? Jaundice. Yes, true, jaundice symptoms are going to be seen. This unconjugated bilirubin at the end of the day will be converted into conjugated bilirubin. So conjugated bilirubin levels will also be more. So this conjugated bilirubin increases the risk of more conjugated bilirubin. More bilirubin is there. Now this bilirubin will form bilirubin gallstones. Okay, so the bilirubin is going to bind with the calcium, forms calcium bilirubinate and forms the pigmented gallstones, not the cholesterol gallstones. Pigmented gallstones can be seen. Possible. Okay, so in this patient there is a risk of jaundice, there is a risk of gallstones, etc. Now in these patients, one more thing. So there is excessive severe hemolysis is happening, right? As there is a severe hemolysis, there is expansion, okay, there is expansion of this hematopoietic activity. Okay, now you have to compensate the loss. There is expansion of the hematopoietic activity to the skull bones. Expansion of, or I should say massive erythroid hyperplasia. Massive erythroid hyperplasia in the sense, now there is expansion of the hematopoietic activity not only to the long bones. Now it's not only just restricted to the long bones. Now hematopoietic activity, it's happening in the skull as well as the facial bones. The skull as well as the facial bones. And next thing, so these patients are going to have hepatomegaly. Why? Because at the end of the day, because of the arthrosplenectomy, spleen is gone. Now all the RBCs have to be destroyed in the liver. So liver is increasing in size. So these patients are going to have hepatomegaly. Okay, hepatomegaly is going to be seen. Now one point which I have forgot is, these patients as a complication, renal papillary necrosis, dactylitis, arthrosplenectomy, acute chest syndrome. See, these patients are at a risk of getting osteomyelitis also. Okay, osteomyelitis. So what is the most common cause of, okay, what is the most common cause of osteomyelitis in these patients is salmonella. Okay, the salmonella paratyphi can lead to, okay, because of the because of this vaso-occlusion within the bone. Okay, vaso-occlusion is happening now within the bone, sir. So that will cause osteomyelitis. Okay, osteomyelitis. What is the most common organism is going to salmonella. Salmonella paratyphi. Salmonella paratyphi is the cause of osteomyelitis. True. So these are some important points which I want you to know. These patients are going to, if you look at the reticulocyte count, yes, definitely reticulocyte count. Reticulocyte count is going to be more than 3%. And if you take an X-ray, okay, if you take an X-ray in these patients, due to the massive erythroid hyperplasia, the hematopoietic activity is happening in the face and facial bones as well as the skull bones. In these patients, there is going to be hair on end appearance. Hair on end appearance. I have shown you that image also. In the previous videos, I have shown you like hair on end appearance or crooked appearance of the skull, where the skull looks like the spikes are coming out of the skull. So X-ray shows this thing. Okay. So at the end of the day, the point which I want you to know, okay, the point which I want you to know is these patients are having abnormal hemoglobin. It is HbS, which will undergo polymerization, which will lead to the damage to the cell membranes due to sickling and unsickling. Okay, sickling as well as desickling. If you do hemoglobin electrophoresis, Hb electrophoresis, you can see HbS type of hemoglobin. HbS type of hemoglobin, and as a treatment for these patients, we will give hydroxyurea. So what is the point of giving hydroxyurea to these patients? Is hydroxyurea. See, hydroxyurea, we don't know the mechanism how it increases the level of Hb. Okay, it increases the levels of HbF. So that HbF is going to be something good in these patients. Okay, because HbF is protective, right? It's a protective, especially in the childhood. Now, if you give hydroxyurea, it increases the levels of HbF, so that HbF is going to do its job. Okay, this is one point which I want you to know. So with this, the extravascular hemolysis, okay, the normocytic anemias where there is extravascular hemolysis, that is sickle cell disease, as well as hereditary spherocytosis are completed. In the next video, we will be discussing about anemias with intravascular hemolysis. Okay guys, hope the video is helpful. Thank you.